Happy Halloween, and thank you for joining me today at the Paper Trail segment of Woundwire. My name is Tony Turner, and I am the Executive Director of Enrich Advisors, and I'm joining you today via Skype from our corporate office in the Woodlands, Texas. Today, we're going to talk a little bit about a very scary subject for a lot of providers out there, and really for all providers out there, and that is the idea of whether or not the payers, Medicare especially, is coming to get your money. In the old days, what was we all focused on is getting paid. And these days, the thought is, are we able to stay paid? And staying paid, the key focus needs to be from the provider is the understanding that does my documentation give voice to the claim? You have to keep in mind that Medicare is going bankrupt, and they are projected, it's been reported for them to be going bankrupt in the year 2024 or 2016, depending on how Obamacare affects their solvency. And certainly a large reason for this has been due to the improper payments. Those are a big problem that providers have been paid money that they should not have. So they are coming to get your money, or I should say their money. They want their money back for the services and supplies that were billed improperly. That is why they have put together different programs. You see acronyms, the RACs, ZPICs, certs, all based on a recoupment program and in an auditing fashion. So a provider would be well served to approach this is not a matter of if, it truly is a matter of when you are audited for potential recoupment dollars. RAC auditors are definitely the key auditors that most providers are familiar with. These are contractors that work on commission, and they receive a percentage of whatever they find has been improperly paid. That means anything that was overpaid, they get a percentage, or anything that was underpaid, they get a percentage. So they really do roll over all stones to find the errors of the providers. They use proprietary software programs to look for anomalies and duplicate payments, and they will do automated reviews through just the claims, looking to see if you spike an anomaly of how your billing practices are. And then they may start asking for documentation and even coming on site to review and in a comprehensive audit. So it's very important to remember when you set up your own internal audit programs that you should be reviewing yourself as a RAC auditor does. And that is that you know that your E&M levels, your visit codes, are you really having a distribution over time over the 5 levels should be an E&M distribution over all 5 levels, and not just if any one encounter is equating to a certain point level based on the tool that you've devised, but do you have the expected bell curve over a time period? That's what they're looking for, and that's what you should be reviewing as well. The top 5 reasons that have been reported for recoupments for improper payments by the RACs have been related significantly to medical record documentation. The top 3, one being medical necessity. The second one also being that things were coded incorrectly, whereas the diagnosis codes that were mentioned in documentation did not meet the diagnosis codes that were on the claims, as well as the inability to have enough documentation or conflicting documentation, or simply things were not documented at all. So there's lots of ways. So the top 3 being directly related to medical record documentation. That's important to know that those are key things that they're going to be looking for, and they are key things to hanging on to your money. So the medical record itself should read definitely like a story about the patient's condition that you saw each time. A good medical record gives the reader perhaps even years down the road and an understanding of what went on to treat and why you decided to treat that patient. Also, we have we have physicians who aren't very mindful about their medical record documentation, and they like to take shortcuts, and they feel like they have pretty much performed medical necessity once they have diagnosed the patient. Unfortunately, when you're seeing a patient for a series of care, that cannot be the case. And just because they don't like to type, or maybe they don't like to spend time writing, the excuses are neither charming nor persuasive, according to the OIG, who is like the FBI of medical records. So let's talk about what the options that are out there. When I'm out there auditing, here's the typical option, and hyperbarics especially. This is one that I am seriously concerned that our industry is potentially going to be hurt from not demonstrating good medical necessity. Typically, you will see a physician who may write down the diagnosis code, and it may be definitely a covered diagnosis code, like diabetes, with a diabetic ulcer, and they will definitely order the treatments, and they'll put the diagnosis code down, and they'll put how long to treat the patient. And they feel that they pretty much have captured medical necessity. However, in the second option that I commonly see is that the mechanisms of action of HBO are also listed in a very long published format, and maybe they will cut and paste these verbatim from a published materials and put them in the documentation. As well and good as that is to show that that is certainly the efficacy is there for that condition, it's very important that you show that this is connected directly to the patient's care, not just because the doctor said so or that modality works on that condition. Remember that indication and medical necessity are not one and the same, and that indication supports medical necessity. The indication is your diagnosis code, certainly, but that's not enough to tell the whole picture. You have to review the facts, describe the patient's history in light of specific coverage policies, and make sure that you tell the story. And connecting those dots, just like in the dot-to-dot game, can definitely give you a better picture. So that being said, you really have to make the case for each patient at every encounter, gather the evidence, and make the case. Support the ICD-9 code that you have chosen, and make sure that you relate it to the patient that's in front of you. The conflicting documentation that I commonly find on auditing is usually done between nursing assessments and physician documentation for procedures, both of which happen in the same encounter. You have to remember this is a shared encounter and a shared document. So the nurse's notes definitely should rhyme with what the physician writes in his procedure notes. And commonly, in this case, you'll see that the nurse had assessed the wound and she found very little that she could visualize in the wound. She saw very little eschar, very little, well, she saw no eschar and very little slough, and it was granulated quite well, as well as epithelialization. However, in that same encounter, a debridement was performed. As a matter of fact, it was a muscle debridement that was removed on this patient, and the entire and billed in the entire amount of size of the wound. And eschar was reported, as well as a multiple of other materials in the wound that was not mentioned by the nurse. Now, 4 months later, and 8 more muscle debridements on this very same patient, as you can see in this wound assessment that the nurse did, she documented that there was an improved wound, an improved status, and very little slough. There's no eschar. Granulation was 76 to 100%. It sounds like a very healthy wound at this point. However, in that very same encounter, again, a muscle debridement was performed, removing exudate and fibrin and mentioning more than what the nurse assessed. So here's an example of good conflicting information, as well as the fact that there was no narrative done when the procedure was also done. So this sets you up for a perfect storm for conflicting documentation. You also important to recognize that your payers may have utilization guidelines, and how many times you debride is a key utilization that you should be familiar with. And in a recent Enrich audit that was performed, we found there had been a patient that was in service for 12 months with a mastectomy wound having received 39 muscle debridements on the same wound. And let's be honest, if a patient received 39 muscle debridements in the outpatient setting, there's a bigger problem there, and that patient probably shouldn't be as an outpatient. So in conclusion, I thought this quote was a very, very good quote to kind of fit with our Halloween theme, as well as what some of our payers might feel when they receive those claims that don't give voice to the documentation. Thank you for joining me today, and I hope this has helped enrich you in understanding a little bit more about medical necessity and RAC auditing.